Good evening all, and this is about aromatic amino acid metabolism and its disorders. Now the first, what are the three aromatic amino acids? They are mainly phenylalanine, tyrosine and tryptophan, right? So we'll start with phenylalanine. So what is phenylalanine? It is an aromatic amino acid. It is an essential amino acid. It has to be taken via diet, yes, and both glucogenic and ketogenic. So as we learn the pathway, we will be able to understand why phenylalanine is considered both glucogenic and ketogenic. Now phenylalanine gets converted to tyrosine. So what is the first reaction the phenylalanine undergoes? The phenylalanine gets converted to tyrosine. So how does phenylalanine gets converted to tyrosine? What is the enzyme which is necessary for this conversion? The enzyme is phenylalanine hydroxylase. Yes, the enzyme is phenylalanine hydroxylase. Now what is the function of this enzyme is to convert phenylalanine to tyrosine. So the other name for tyrosine will be called as hydroxyphenylalanine. Alright, hydroxyphenylalanine. So now for conversion of this phenylalanine to tyrosine, since it is an hydroxylase enzyme, it's a monooxygenase. So oxygen is utilized. One oxygen is incorporated in the phenylalanine forming tyrosine. The other oxygen is incorporated to form water. And the next cofactor which you need is tetrahydrobiopterin. Yes, tetrahydrobiopterin. Now what is tetrahydrobiopterin? Gets utilized and gets converted to dihydrobiopterin. Yes, dihydrobiopterin. Now to regenerate tetrahydrobiopterin, we use NADPH. Yes, to regenerate tetrahydrobiopterin, you use NADPH. Yes, so this is the reaction of conversion of phenylalanine to tyrosine. So what is the enzyme which regenerates the tetrahydrobiopterin? It is a dihydrobiopterin reductase. Yes, dihydrobiopterin reductase. That which converts the dihydrobiopterin to tetrahydrobiopterin. So what is the enzyme that converts phenylalanine to tyrosine? It is phenylalanine hydroxylase. Now let us see a case. Identify what case it is. A 20-year-old boy with severe mental retardation, mousy odor in the body fluids, hypopigmentation. The patient had frequent episodes of seizures and aggressive behavior. What is your diagnosis, all of you? Yes, what is your diagnosis? Yes, the diagnosis is phenylketonuria. Yes, the diagnosis is phenylketonuria. So what is the cause of phenylketonuria? The phenylketonuria, the cause is deficiency of phenylalanine hydroxylase. So the classical phenylketonuria, the deficiency of phenylalanine hydroxylase, that is classical phenylketonuria. Yes, very good, it is phenylketonuria. Why do we call this as phenylketonuria? Because we can see there is severe mental retardation, there is mousy odor in the body fluids. So what is the reason for this mousy odor in body fluids? It is because the accumulation of phenylketones. Yes, accumulation and excretion of phenylketones in the urine is responsible for the mousy odor in the body fluids, especially in your urine. And hypopigmentation, because phenylalanine gets converted to tyrosine, and tyrosine is necessary for synthesizing melanin, a skin pigment. Yes, when there is reduced phenylalanine conversion to tyrosine, then there is reduced melanin, so hypopigmentation is what you get. And severe mental retardation, because increased accumulation of phenylalanine in the circulation is responsible for severe mental retardation, other episodes of seizures and aggressive behavior. Okay, so what are the symptoms of phenylketonuria that we saw? The symptoms of phenylketonuria will be, the first one is accumulation of phenylalanine. So increased phenylalanine in the circulation gets converted to phenylketones. phenylketones like phenyl pyruvate, phenyl lactate, phenyl acetate. Yes, and these phenylketones are excreted in urine. That is why we call this disease as phenylketonuria. Yes, and this will lead on to mental retardation. So classical PKU will lead to mental retardation, and there will be convulsions or seizures, aggressive behavior in the child, and there is hypopigmentation due to decreased melanin synthesis, due to decreased tyrosine. Yes, and because of this phenylketones in the urine gives mousy body odor, because of excretion of phenylketones. Yes, because of phenylketones. Now, what is the treatment for this phenylketonuria? The treatment of phenylketonuria will be restricted phenylalanine in the diet. Yes, restricted phenylalanine in the diet. Now, there are different types of phenylketonuria. One is the classical type, which is type 1, which is due to the enzyme deficiency, phenylalanine hydroxylase deficiency. Now, there are other types like type 2 and 3. So, we had already seen there is necessity of tetrahydrobiopterin. Yes. So type 2 and 3 are due to deficiency, the causes which can lead to dihydrobiopterin reductase enzyme. Dihydrobiopterin reductase is essential for regenerating tetrahydrobiopterin. So if this enzyme is defective, then it will lead to phenylketonuria. Then there are type 4 and 5, which will be due to deficiency of the enzyme synthesizing biopterin. So because we need tetrahydrobiopterin, the biopterin synthesizing enzyme, if it is deficient, even that will lead on to phenylketonuria. Yes. So the severe form is the classical form, which is phenylalanine hydroxylase deficiency. Right. So the treatment part we had seen. What are the different tests that we can do? One is we can estimate the phenylalanine levels in the circulation. Yes or no? Next is tandem mass spectrometry, which is helping in finding out the phenylketones. Yes, and then there is a specific test like Guthrie's test. It's a screening test, and also we have ferric chloride test, which will be positive for phenylketones when it is present in urine. Yes, so these are different, and there is genetic screening. Yes, so these are some of the investigations which can be done in case of phenylketonuria. So this is about phenylalanine. So now let's discuss about tyrosine. Yes, now let's discuss about tyrosine. So from phenylalanine we have got tyrosine. So what is the fate of this tyrosine? The first step in tyrosine is tyrosine. What is tyrosine? I had told you it is hydroxyphenylalanine. Yes. Now this alanine is going to get transaminated. Yes, transaminated with the help of the enzyme tyrosine transaminase. With the help of the enzyme tyrosine transaminase. Understood? So transaminated, what should you need in case of transamination reaction? When an amino acid is present, you remove the amino group of the amino acid and give it to a keto acid. So alpha ketoglutarate is what you add. So alpha ketoglutarate gets converted to glutamate, whereas the tyrosine, which is the hydroxyphenylalanine, gets converted to para-hydroxyphenylpyruvate. Yes, alanine gets converted to pyruvate on removal of the amino group. So para-hydroxyphenylpyruvate. And we all know tyrosine, any transamination reaction will need pyridoxal phosphate. Yes, pyridoxal phosphate. Now this para-hydroxyphenylpyruvate is going to get converted to what? Dihydroxyphenylacetic acid. Yes, dihydroxyphenylacetic acid. Dihydroxyphenylacetic acid. Now what is this? What is the other name for this dihydroxyphenylacetic acid, all of you? Yes, what is the other name for this? The other name is homogentisic acid. Is it not? The other name is homogentisic acid. Yes. So what is the enzyme that converts the para-hydroxyphenylpyruvate to a homogenesic acid? It is dioxygenase. Yes, it is dioxygenase. That is para-hydroxyphenylpyruvate dioxygenase or hydroxylase. Yes, so tyrosine gets converted to para-hydroxyphenylpyruvate, that gets converted to homogenesic acid. Now this homogenesic acid, what does it get converted to? It gets converted to mallyl acetoacetic acid. Mallyl acetoacetic acid. Now this gets isomerized to fumaryl acetoacetic acid. Fumaryl acetoacetic acid. Now what is the enzyme that converts homogenesic acid to mallyl acetoacetic acid? It is the famous enzyme homogenesate oxidase. Yes, or homogenesic acid oxidase. Homogenesic acid oxidase. Now mallyl acetoacetic acid is getting isomerized. So this enzyme is an isomerase. Now this fumaryl acetoacetic acid is going to get cleaved, okay, going to get cleaved by a hydrolase to fumarate, yes, to fumarate an acetoacetic acid. Yes, to fumarate acetoacetic acid. Now what is the enzyme? It is fumaryl acetoacetic hydrolase. Yes, fumaryl acetoacetic hydrolase. Yes, this is an hydrolase enzyme. Alright. So tyrosine to para-hydroxyphenylpyruvate by tyrosine transaminase, para-hydroxyphenylpyruvate to homogenesic acid by a dioxygenase. Yes, first transamination reaction, after which is dioxygenase, oxygenation reaction. Then homogenesic acid is getting converted to mallyl acetoacetic acid by a homogenesic acid oxidase. Yes, and mallyl acetoacetic acid is going to get isomerized to fumaryl acetoacetic acid, which is then cleaved to fumarate and acetoacetic acid by fumaryl acetoacetate hydrolase. Yes, so now do you understand why we call this phenylalanine and tyrosine as both glucogenic and ketogenic? Because it gives the two products, fumarate, which can enter into the gluconeogenic pathway, which is a intermediate of your TCA cycle. So then acetoacetic acid, which is a ketone body, which is ketogenic. All right. So it's both glucogenic and ketogenic. All right. Now let's talk about the metabolism disorders associated with the tyrosine metabolism. There are mainly two disorders. Yes, one is tyrosinemias. And the other one is alkaptonuria. So now tyrosinemia, there are three types, 1, 2 and 3. So what is the cause of tyrosinemia type 1? The type 1 tyrosinemia is due to the deficiency of the last enzyme of the pathway. Alright. So I'll tell you few points related to these tyrosinemias and alkaptonurias, after which we will discuss this or learn the same with the help of a case. Alright. Now tyrosinemia type 1 is due to fumaryl acetoacetate hydrolase deficiency. Yes, it is the deficiency of the enzyme of the last reaction of this pathway. Now fumaryl acetoacetate hydrolase. So if this enzyme is defective, what happens? Fumaryl acetoacetate gets accumulated in the circulation. Alright. Now this fumaryl acetoacetate can get converted to a succinyl acetoacetate, which in turn can get decarboxylated to form succinyl acetone. So this succinyl acetone is toxic to your kidney and liver. That is why this type is called hepatorenal tyrosinemia. This type is called hepatorenal tyrosinemia. Also, this succinyl acetone can inhibit an enzyme called ALA dehydratase, Yes, ALA dehydratase, which is an enzyme of your heme synthesis. So if this ALA dehydratase is going to be deficient, if it is going to be inhibited, if it is going to be inhibited, then your ALA gets accumulated in circulation. This can mimic porphyrias. Yes, so your fumarate acetoacetate can give you succinyl acetone. The succinyl acetone can inhibit ALA dehydratase, which is an enzyme of your heme synthesis pathway, thereby leading on to porphyria-like symptoms. Yes, so tyrosinemia, which is leading to porphyria-like symptoms, is type 1 tyrosinemia. Understood? Also, since it is toxic to your kidney and liver, you call this as hepatorenal tyrosinemia. Yes. So in children, what will happen? There will be elevated alpha fetoprotein in circulation. Also, you will find hepatomegaly. Yes, you find hepatomegaly, jaundice, cirrhosis, hepatocellular carcinoma. So these symptoms, these features are also present in type 1 tyrosinemia. Now let's discuss about type 2 tyrosinemia. So what is type 2 tyrosinemia? Type 2 tyrosinemia is due to the defect of tyrosine transaminase. Due to the defect of tyrosine transaminase. Yes. So now that is called as oculocutaneous tyrosinemia. Now here there will be features in eyes like painful corneal erosions and also palmakeratosis, which is cutaneous manifestation. So this type 2 tyrosinemia, which is due to tyrosine transaminase, which is type 2, right? So that is nothing but oculocutaneous tyrosinemia. Now there is one more type, which is type 3 tyrosinemia, when there is complete absence of hydroxyphenylpyruvate dioxygenase. Yes, when there is complete absence of this hydroxyphenylpyruvate dioxygenase enzyme, it will lead to type 3 tyrosinemia. Yes, when there is partial defect of this enzyme, that will lead to transient tyrosinemia of newborn. Yes, when there is gain of function mutation, then it will lead to Hartnup. There is stimulation of this enzyme. Okay, that will lead to Hartnup. So these are the different tyrosinemias. So let's repeat. Tyrosinemia type 1 is due to fumarate acetoacetate hydrolase enzyme. Yes, fumarate acetoacetate hydrolase. Type 2 tyrosinemia is due to tyrosine transaminase. Type 3 tyrosinemia is due to hydroxyl phenylpyruvate dioxygenase. Yes, so these are the three tyrosinemias. Now what is alkaptonuria? Alkaptonuria is due to deficiency of homogentisate acid oxidase or homogentisate oxidase. That is alkaptonuria. That will lead on to excessive accumulation of homogentisic acid in the circulation. Now even that can get oxidized to benzoquinone acetate. Yes, that can get oxidized to benzoquinone acetate on exposure to air. That is nothing but your ochronotic pigment. Yes, that is your ochronotic pigment. So this is why your urine turns black when you keep it for some time. So these benzoquinone acetate is a black colored pigment. So your urine will turn black on standing. Also there is ochronosis, which is nothing but deposition of this pigment in your connective tissues. Yes, so that will lead to deposition of this ochronotic pigment in your intervertebral discs or in your eyes along the insertion of your ocular muscles. Yes, in the pinna. So in these are some of the areas where this pigment can get deposited, that is ochronosis. All right. So these are the different disorders. Now let's learn this again with cases. All right. Now look at this first case. Give me the answer. Now a 6-year-old boy presents with periodic aggressive behavior. His urinary ALA is elevated. On examination, he is jaundiced. and a mild hepatomegaly is observed. There is massive elevation of alpha fetoprotein, and this HPLC and TMS examination revealed elevation of succinyl acetone. So what do you think the diagnosis is? It is very clear. What do you think the diagnosis is? Yes, I am waiting for your answers. Yes. Very good. It is type 1 tyrosinemia. Yes, any other answers? Yes, so it is type 1 tyrosinemia. So why do we call it type 1 tyrosinemia? Because we see that urinary ALA is elevated. This can be due to, yes, very good, all of you, hepatorenal tyrosinemia, which is nothing but type 1 tyrosinemia. Here, what is the reason for this type 1 tyrosinemia? We have already seen it's due to deficiency of fumarate acetoacetate hydrolase. Yes, it's not hydroxylase, it is hydrolase. Alright, now that accumulation of, it's not hydroxylase, it is hydrolase. So we all make this mistake. Yes, so fumarate acetoacetate gets accumulated. That will lead to formation of succinyl acetone. Succinyl acetone is toxic to your liver and kidney. That is why you get hepatomegaly, jaundice, and also renal symptoms, renal failure. That will also, succinyl acetone will also inhibit ALA dehydratase enzyme. So porphyria is mimicked. Okay, you mimic porphyria in this. That is why we get elevated urinary ALA, hepatomegaly, jaundice, and massive elevation of alpha fetoprotein. Yes, an elevation of succinyl acetone. This all points to type 1 tyrosinemia. So the three types we have, as we had already discussed, we will see what is the type 1 tyrosinemia. It is hepatorenal syndrome. Type 2 is oculocutaneous syndrome. Type 3 is neonatal tyrosinemia. Now what is the enzyme deficiencies? Fumarate acetoacetate hydrolase deficiency in type 1. Please revise these three types now itself. Type 2 is due to tyrosine transaminase. Yes, 2 T's. TT, type 2, tyrosine transaminase. Type 3 is para-hydroxy phenylpyruvate hydroxylase or dioxygenase. Now features, if you say, the features are all due to succinyl acetone and porphyria, that mimics porphyria. It's hepatorenal. Yes. And type 2 is also called as Richner-Hanhart syndrome. What are the features of type 2? It's painful corneal erosions. It's ocular manifestation. Cutaneous manifestation will be palmar hyperkeratosis. And type 3, if you take, partial defect will lead to transient tyrosinemia of neonates. Gain of function mutation will lead to Hawkinsinuria. And it will lead, symptom will be, the feature, clinical feature can be intermittent ataxia. Right, so these are the three types of tyrosinemia. Now let's see another case. Now tell me what this case is. A 5-year-old boy came to OP. His mother gave a history of dark black color on the diapers for a few months of life. Clinical examination, active, alert, no pallor, no jaundice. There is no significant clinical history. And then on testing urine for reducing substance, Benedict's reagent gave a strong positive. For urine serum chromatography, homogenesic acid level was very high. So this is also given. Homogenesic acid level was high. That is also given. So it very clearly points to alkaptonuria. Yes, points to alkaptonuria. Now what is the feature, what is the deficiency in alkaptonuria? It is homogenesic acid oxidase deficiency. So homogenesic acid gets accumulated, that gets oxidized to benzoquinone acetate, that is the ochronotic pigment. That is responsible for turning urine to black on standing. So when it is exposed to air, there is oxidation of homogenesic acid if at all it's present in this urine, and hence it becomes black. Now along the insertion of ocular muscles, it becomes there is deposition of ochronotic pigment, and along the pinna, so the ochronotic pigment gets deposited in the connective tissues. Also, otherwise, except for these ochronotic pigment deposition or urine turning black on standing, that is the first symptom. Okay, urine turning black on standing is the first symptom. So except for this, the patient will lead a normal life. But the ochronotic arthritis, if it starts manifesting, then that is crippling. Okay, so ochronotic arthritis, that is the deposition of this ochronotic pigment in your intervertebral discs and other joints. Okay, so now this is what is alkaptonuria. So we've seen about tyrosine metabolism, the pathway, that is the main pathway, catabolic pathway we have seen. What are the special products of tyrosine? They are mainly melanin, which is the skin pigment, catecholamines, adrenaline, noradrenaline and dopamine, and then thyroxine. So these are the special products of tyrosine. Now let's see how these three products are derived from tyrosine. So from tyrosine, what is the enzyme that converts, yes, what from tyrosine? Tyrosine gets acted upon by tyrosinase enzyme. Okay, tyrosinase enzyme. When it is acted upon by tyrosinase, what forms? What forms dihydroxyphenylalanine, which is DOPA. Dihydroxyphenylalanine gets formed. Alright, now this DOPA becomes dopaquinone, indolquinone, and the final product will be melanin. So melanin is the skin pigment. Yes, melanin is the skin pigment. So the only enzyme is tyrosinase. Yes, the only enzyme is tyrosinase in this pathway. So tyrosine getting converted to dihydroxyphenylalanine, and after 2-3 reactions it forms melanin, a skin pigment. Now look at this. What is the diagnosis? What is the diagnosis for this picture? Yes, all of you, what is the diagnosis? Yes, it's very clear. The patient is hypopigmented. Yes, I'm waiting for your answers. Yes. So the patient is hypopigmented. They will be sensitive to UV rays. Yes, they are more prone for developing melanomas. So it is nothing but albinism. It is nothing but albinism. So what is the reason for this albinism? What is the deficiency in albinism? The deficiency in albinism is, which is the only enzyme which is involved in forming the skin pigment melanin? Yes, the only enzyme is tyrosinase. So tyrosinase deficiency is what causes albinism. Tyrosinase deficiency causes albinism. So there is generalized hypopigmentation. So the patient will be sensitive to UV rays. So there is photophobia and nystagmus also. Yes, even the ocular fundus is hypopigmented. Iris will appear either grey or red, and there is decreased visual acuity. And they are also prone for developing cancers, melanomas, right? So this is about albinism. Now let's talk about tyrosine getting converted to catecholamine. So one more special product of tyrosine is catecholamine. So which is the first enzyme? Which is the first enzyme tyrosine gets acted upon by? Tyrosine gets acted upon by tyrosine hydroxylase. Yes, tyrosine hydroxylase. So even if it's getting acted upon by tyrosine hydroxylase, what does it form? It forms dihydroxyphenylalanine. Yes, dihydroxyphenylalanine. Now even, yes, DOPA. Okay, dihydroxyphenylalanine. So even in the melanin We saw tyrosinase converts tyrosine to dopa, is it not? So in albinism, even in patients with albinism, this synthesis of catecholamines is not affected because tyrosine hydroxylase enzyme converts tyrosine to dopa and further catecholamines are synthesized. Okay. Now this tyrosine hydroxylase is similar to phenylalanine hydroxylase which we studied earlier. So what are all the things which you need for phenylalanine hydroxylase? We studied we need tetrahydrobiopterin and NADPH, is it not? So similarly, even in this tyrosine hydroxylase, the cofactors will be tetrahydrobiopterin and NADPH. Yes, the same things, the same as that of phenylalanine hydroxylase. Now this dopa gets converted to dopamine. Yes, dopa gets converted to dopamine by a decarboxylase reaction. So any decarboxylase will need pyridoxal phosphate. Yes. So which is the enzyme here? It is dopa decarboxylase. The enzyme is dopa decarboxylase. Now this dopamine is going to get converted to norepinephrine. So the first one is norepinephrine by dopamine hydroxylase. So what is the enzyme? It is dopamine hydroxylase. Yes. So this is a copper containing enzyme. You also need vitamin C for this reaction. Now norepinephrine, how does it get converted to epinephrine? Norepinephrine to epinephrine, how do you convert? You methylate. Yes, methylation will convert norepinephrine to epinephrine. So S-adenosine methionine will be the donor, methyl donor. So a methyl transferase enzyme converts norepinephrine to epinephrine. Now this epinephrine can get converted to metanephrine. The metanephrine can get converted to vanillyl mandelic acid. Yes, whenever there is excess of epinephrine, there is excess of vanillyl mandelic acid excreted in the urine. Alright. Now tyrosine hydroxylase converts tyrosine to dopa. That is similar to phenylalanine hydroxylase reaction where tetrahydrobiopterin and NADPH are required. Now this dopa gets converted to dopamine by a decarboxylation reaction that needs pyridoxal phosphate as its coenzyme, and dopamine gets converted to norepinephrine by dopamine hydroxylase, which is a copper containing enzyme, and norepinephrine gets converted to epinephrine by methyl transfer, and epinephrine to metanephrine, and metanephrine to vanillyl mandelic acid are degradation products or catabolic products of epinephrine. Yes. So this is how the catecholamines dopamine, norepinephrine and epinephrine are synthesized from tyrosine. Alright. Now let's see another case now. A 30-year-old male came with profuse sweating, headache and symptoms of panic attack. His blood pressure was elevated when he checked it many a times before during the last few weeks, and he had tachycardia. Now his urine showed increased excretion of vanillyl mandelic acid, VMA. So what is the probable diagnosis you could think of? Yes, what's the probable diagnosis you could think of? There is symptoms of profuse sweating, headache and symptoms of panic attack. BP was elevated, there is tachycardia, VMA in the urine. So what is the probable diagnosis? Yes. Yes, any others? What is the probable diagnosis? Yes, any others who could find out the diagnosis? Yes, so it is pheochromocytoma. What is the diagnosis here? Pheochromocytoma. So what is pheochromocytoma? Now it is pheochromocytoma. What is pheochromocytoma? It's nothing but tumor of your adrenal glands. Yes, tumor of your adrenal glands. So what are the symptoms which will make us think about this pheochromocytoma? So this tumor will synthesize more of epinephrine. Yes, tumors will synthesize more of catecholamines, especially epinephrine. So if more of epinephrine is released, what will be your classical triad in case of pheochromocytoma? You get profuse sweating, episodic headaches and tachycardia. Yes, so due to adrenaline action, there is elevated blood pressure also. There is elevation of blood pressure also. So these things will point towards pheochromocytoma. Also there is excretion of VMA. So we have already seen what is the catabolic product, end product of this epinephrine. It is VMA. It gets converted to metanephrine and then VMA. So VMA metanephrines will be elevated in your urine when you find out. So there is excretion of these products in the urine. So this is a case of pheochromocytoma. Yes. So now the next product is tyrosine to thyroxine. Yes, tyrosine to thyroxine, helping in formation of thyroxine. How is it possible? Thyroxine is a thyroid hormone, is it not? So in the thyroid follicle, we have got a protein called thyroglobulin. Yes, thyroglobulin. This thyroglobulin will have many tyrosine residues on it. It will have many tyrosine residues on it. So these tyrosine residues, when it gets iodinated, yes, these tyrosine residues, when it gets iodinated, can form monoiodotyrosine and diiodotyrosine. When these couple, yes, when mono with diiodotyrosine couples, it forms triiodothyronine. When two diiodotyrosine couples, it forms thyroxine. Okay, so the iodination of your tyrosine residues in thyroglobulin is responsible for synthesis of thyroid hormones. So that is how tyrosine helps in forming thyroid hormones. Yes, so with this we are completing tyrosine metabolism. So special products of tyrosine will be mainly melanin, catecholamines and thyroxine, right? So now let's learn about tryptophan metabolism. Tryptophan metabolism, what is the tryptophan? It is an aromatic amino acid. It is an essential amino acid. Whereas tyrosine, is it an essential amino acid? Tyrosine is formed from phenylalanine, is it not? So it is an aromatic amino acid, but it's a non-essential amino acid because it is synthesized from phenylalanine. Okay. Now this tryptophan, this is an essential amino acid. It has an indole ring in its structure. It is both glucogenic and ketogenic. So all three aromatic amino acids are glucogenic and ketogenic. Now the catabolic pathway of tryptophan, if we have to learn, it is about tryptophan getting converted to N-formylkynurenine. So what is the first reaction you should know about? Tryptophan getting converted to N-formylkynurenine. So what is this? It is done by the enzyme tryptophan pyrrolase. Yes, what is the enzyme involved in this reaction? It is tryptophan pyrrolase, converts tryptophan to N-formylkynurenine. So you have to know about few things with which you will be able to understand the tryptophan products, special products. Okay. Now this N-formylkynurenine gets converted to kynurenine by removal of this formyl group. So what is formed? A formyl THFA is formed. So with the help of THFA, you give THFA and form and release the formyl group from the substrate, forming formyl THFA, which now becomes one donor in one carbon pool. Yes, donor of formyl group in 1 carbon pool. Now this kynurenine gets converted to 3-hydroxykynurenine. Now 3-hydroxykynurenine with the help of the enzyme kynureninase. Yes, with the help of the enzyme kynureninase gets converted to 3-hydroxyanthranilic acid. Now this reaction is important. In this reaction, it also releases alanine. Yes, so release of this alanine makes this amino acid glucogenic. Yes, makes this amino acid glucogenic. Now kynurenase is an enzyme which is dependent on pyridoxal phosphate, Now what happens in pyridoxal phosphate deficiency? If there is pyridoxine deficiency or B6, vitamin B6 deficiency, then your 3-hydroxyanthranilic acid is not formed. In the next slide, we will be seeing how niacin is formed from 3-hydroxyanthranilic acid. Yes, so now you can think of why B6 deficiency will lead to pellagra-like symptoms. Niacin deficiency causes pellagra. So if pyridoxal phosphate is deficient, B6 is deficient, then niacin cannot be formed because niacin has to be formed from hydroxyanthranilic acid. Alright, now instead if this step is blocked, so kynurenase is blocked, so your kynurenine is getting elevated in the circulation, which can form xanthurenic acid, Now you will find xanthurenic aciduria. Yes, xanthurenic acid in the urine in case of pyridoxal phosphate deficiency. Alright, so tryptophan, let's again revise tryptophan to N-formyl kynurenine by the enzyme tryptophan pyrrolase. And N-formyl kynurenine to kynurenine, it removes a formyl group. So this formyl THFA now becomes a part of 1 carbon pool. Now this kynurenine forms 3-hydroxykynurenine. 3-hydroxykynurenine forms hydroxyanthranilic acid, which is an important initiator of niacin synthesis. So this is done by the enzyme kynureninase, which is pyridoxal phosphate dependent. During this reaction again alanine is released. Now this reason why alanine is released, because of this tryptophan becomes glucogenic. Alright. Now if there is pyridoxal phosphate deficiency, there is niacin deficiency, because 3-hydroxyanthranilic acid is necessary for forming niacin. So if that pyridoxal phosphate is deficient, kynurenine gets increased in circulation. It forms xanthurenic acid, which is excreted in the urine. Yes, now do you understand these points? Now this hydroxyanthranilic acid, after a series of reactions, becomes acetoacetyl-CoA. Now this acetoacetyl-CoA, because of this synthesis, this tryptophan becomes ketogenic. Yes, so now tryptophan is both glucogenic and ketogenic because of these reasons, because it releases alanine and also acetoacetyl-CoA. And it becomes one donor of 1 carbon pools by forming formyl THFA. Understood? Now this is one major catabolic pathway of tryptophan. So about 97% of your tryptophan will enter into this pathway only, right? So few like 3% of the pathway will be diverted towards nicotinic acid synthesis, which is nothing but niacin. Yes, which is nothing but niacin. Now from 3-hydroxyanthranilic acid, I had mentioned before, 3-hydroxyanthranilic acid only is necessary for niacin synthesis, right? So 3-hydroxyanthranilic acid forms niacin. 3-hydroxyanthranilic acid forms niacin. That is why this product is important. That is why in B6 deficiency, when this is not formed, niacin is not formed and it leads to pellagra-like symptoms. Okay. Now niacin is nothing but nicotinic acid. So if you want to convert it into nicotinate mononucleotide, You have to add a nucleotide. So how you should add one ribose 5-phosphate. So what is the donor of ribose 5-phosphate? It is PRPP, phosphoribosyl pyrophosphate. Yes, so the enzyme will be quinolinate phosphoribosyl transferase. Yes, quinolinate phosphoribosyl transferase, which will give the ribose 5-phosphate group, forming a nicotinate mononucleotide. Now this nicotinate mononucleotide, after ATP reaction, gains adenosine, yes, and forms nicotinamide adenine dinucleotide. Nicotinamide adenine dinucleotide. So these are the steps involved in the nicotinic acid pathway. Now 3-hydroxyanthranilic acid forms niacin, and niacin, after gaining ribose 5-phosphate from phosphoribosyl pyrophosphate, becomes nicotinate mononucleotide. Then after a reaction with ATP, yes, ATP, it forms nicotinamide adenine dinucleotide. Right? This is one pathway. So the major pathway is what we had seen in this picture. Now the minor pathway is the synthesis of niacin. Okay. Now next, what are the other products, special products of the tryptophan? One is serotonin. What are the other special products? One is serotonin. So how is serotonin formed? Serotonin is formed from tryptophan. Tryptophan gets converted to 5-hydroxytryptophan by an enzyme, tryptophan hydroxylase. Yes, tryptophan hydroxylase. This is also similar to the phenylalanine hydroxylase and tyrosine hydroxylase. Yes, how is it similar? What does it need? I had told you. What does it need? It needs tetrahydrobiopterin. And for regenerating this tetrahydrobiopterin, you need NADPH. Yes, this is also similar to phenylalanine hydroxylase and tyrosine hydroxylase, which you have seen in the tyrosine and phenylalanine metabolism. So this is tryptophan hydroxylase, which converts tryptophan to, yes, very good, tetrahydrobiopterin and NADPH are required for this tryptophan hydroxylase, which converts tryptophan to 5-hydroxytryptophan, right, with the help of oxygen. So this is a monooxygenase. So one oxygen is incorporated into the tryptophan, the other oxygen is involved in forming water. Next, what happens? The tryptophan, after getting converted to 5-hydroxytryptophan, gets converted to 5-hydroxytryptamine by a decarboxylase reaction, by removing a carbon dioxide, by a decarboxylase reaction. So all decarboxylase reaction depends on pyridoxal phosphate. So it becomes 5-hydroxytryptamine, which is nothing but serotonin. So what is the other name for serotonin? It is 5-hydroxytryptamine. Tryptamine by decarboxylation of 5-hydroxytryptophan. All right. Now after this serotonin, how will this serotonin be catabolized? The serotonin gets catabolized by monoamino oxidase. Okay, monoamino oxidase enzyme to 5-hydroxy-indolacetic acid. This is one of the excretory products of tryptophan. This is one of the excretory product of tryptophan. You can find this product in the urine. So whenever there is higher levels of serotonin formed, you will find more levels of 5-hydroxy-indolacetic acid in the urine. All right. Now, so tryptophan to 5-hydroxytryptophan by a hydroxylase enzyme, and 5-hydroxytryptophan by a decarboxylase becomes tryptamine, which is serotonin. And serotonin, how does it get degraded? By monoamino oxidase to 5-hydroxy-indolacetic acid. So all these intermediates and products are important. Now this 5-hydroxy-indolacetic acid is an excretory product. Now let's find this case, identify this case now with the help of these points: argentaphenomas, intermittent diarrhea, flushing, sweating, pellagra, 5-hydroxy-indolacetic acid in urine. So with all these points correlates to which diagnosis? Identify the diagnosis. Yes? Fast. Argentafinomas. Symptoms will be intermittent diarrhea, flushing and sweating, pellagra-like symptoms, 5-hydroxy-indole acetic in urine. Yes, very good. What is it? Carcinoid syndrome. It is carcinoid syndrome. Yes? So serotonin is a neurotransmitter. It is a happy hormone. It is also responsible for enhancing gastrointestinal motility. Yes? So in the intestinal tract, there are argentafin cells that can produce serotonin. What are the other sources of serotonin? Mast cells, platelets, yes, GI tract, these are all other sources of serotonin. So one source is argentafin cells of your intestinal tract. Now that will enhance the peristaltic movement, GI motility. So in carcinoid syndromes, there is tumor of these argentafin cells which will produce more of serotonin. Okay, so there is increased GI motility which will lead to intermittent diarrhea. Intermittent diarrhea. Also there is, due to sympathetic reactions, there is flushing and sweating. It's a neurotransmitter, is it not? Next it is, how does pellagra form? Pellagra get manifested. Pellagra is manifested because we have already seen 97% of tryptophan goes through the normal catabolic pathway. Yes. But instead, these are minor pathways. Serotonin and melatonin pathways are minor pathways, where the other percentage of tryptophan gets metabolized. But in case of carcinoid syndrome, what happens? There are so many, there is increased synthesis of serotonin because of these argentafinomas. So what happens? Most of these tryptophan are being utilized for synthesis of serotonin. So niacin is not produced. Okay, niacin is not produced. Yes, so all of which are diverted to serotonin pathway. So niacin is not produced. So what happens? There is niacin deficiency which can lead to pellagra. Also there is much of serotonin. The serotonin can lead to 5-hydroxy-indole acetic acid excretion in the urine, which is a diagnostic. So next special product is melatonin. Serotonin gets acetylated to acetyl serotonin, which gets methylated to form melatonin. Yes, which is the methyl donor S-adenosine methionine. So what is the function of this melatonin? The function of this melatonin, it acts as a biological clock. Yes, it is secreted by pineal gland. It acts as a biological clock. It is responsible for maintaining diurnal rhythm in humans. Yes, this is the function of melatonin. And other products are from the putrefaction of tryptophan. So in the intestinal bacteria will degrade tryptophan and forms scatol and indole compounds. Yes, scatol and indole compounds which are excreted in the feces, and some of which will be absorbed and can be excreted as indole compounds and indican in the urine. Yes, so these are the products of putrefaction of tryptophan. So you may find these products when there is Hartnup's disease. Okay. So what are the special products of tryptophan that we have seen? Alanine, due to which it's called glucogenic. Acetoacetyl-CoA, due to which it's called ketogenic. Also formyl group, niacin. Yes, one amino acid which synthesizes a vitamin is tryptophan. So niacin is produced. Serotonin, melatonin, 5-hydroxy-indole acetic acid and indican are excretory products. So these are the special products of tryptophan. Now let's see another case. A 11-year-old presented with pellagra-like symptoms and ataxia. On urine examination, aminoaciduria and indole compounds were identified. So what is your diagnosis? Yes, what is your diagnosis? We are finishing off with this case. So what is this diagnosis? It is Hartnup's disease. Very good. It is Hartnup's disease. So what is the Hartnup's disease? It's due to defective transport of neutral amino acid in your intestine and kidney. Yes, defective absorption of neutral amino acids in your intestine and kidney. So it's not absorbed as well. It is not absorbed in your kidney also. So what happens? It gets excreted. So tryptophan, phenylalanine, threonine, valine, these are all excreted, which leads to amino acidurias. Also, there is niacin deficiency because you don't absorb tryptophan, so enough tryptophan is not there for niacin synthesis, which leads to pellagra-like symptoms. Other common manifestations will be dermatitis and ataxia and indole compounds. So in this case, what is present? We have pellagra-like symptoms and ataxia. Yes, you also have amino acidurias because of the defective transport of the amino acids, and indole compounds were identified. Yes, so indole compounds will be identified using a test which is called Obermeyer's test. So how do you treat this? You treat with high protein diet and niacin supplementation. Yes, so this is Hartnup's. This is a case of Hartnup's disease. All right. So with this we are completing. So we have seen the metabolism of phenylalanine, tyrosine and tryptophan and the associated inborn errors of metabolism. Okay. So hope this session was useful. If you have any doubts, you can send, or you can send it in the Telegram group also.